So today we are joined by an incredible guest, Dr. Christina Lee. She's a board-certified bariatric surgeon with over 20 years of experience helping patients on their weight loss journey. Dr. Lee is here to share essential knowledge about bariatric surgery, when to consider it, the types of procedures available, and how to determine which surgery might be right for you. Whether you're just starting to explore your options or you've been thinking about surgery for a while, this episode is for you. Thank you, Dr. Lee.
No problem. My pleasure.
So I think we should jump right into it and talk a little bit about what bariatric surgery is, if you don't mind explaining a little bit.
Yeah, so it's weight loss surgery to help change people's anatomy to make it easier to lose weight or to help your body to lose weight. So some people think, oh, do you take off anything while you're doing the surgery? No, we don't do any kind of plastic surgery. It is altering somebody's own inside structures. So we might cut people's stomach or rearrange their intestine in order to help them to lose weight.
Okay, and besides just losing weight, does bariatric surgery have a deeper purpose?
Absolutely. So it is definitely not just to lose weight. It is not a cosmetic thing. It is to help, that can be a side benefit, but it is mainly to help people get healthier. So obesity is definitely a chronic disease. It is not necessarily the fault of somebody for not paying attention or something, which is a common belief in our society. But it is a disease that we can treat both with medications and with surgery. And certainly there are many obesity-related diseases that can occur. So it's to help people get healthier by losing weight. A lot of those diseases will go away or go into remission. So by treating someone's obesity, we can treat a lot of medical problems all at once. So it can be a really efficient way of taking care of people's health problems or avoiding potential health problems in the future.
That's a very good point. So it's not only for the diseases you have now, but it can help you not develop further diseases.
That's right. It can be preventative. It can, and it can be things that people don't think about. It can be, there are, for example, multiple obesity-related cancers. So it can help prevent cancer. It can help enhance people's fertility. It can increase testosterone levels in certain cases. It can help with heartburn, with sleep apnea. It can help with, there's a disease where there's too much pressure on your brain. It can help with that. So it has wide-reaching effects beyond most people know about high blood pressure and diabetes. But there's so many other things that are affected. And from a physical standpoint, so it's not only for health reasons, but it's also for capacity reasons and what people can do afterwards. If they lose essentially a whole nother person or a teenager from getting off their back, you can do so much more. You can walk further. You can jog.
Spend time with your kids.
You can spend time outpacing your family, where before they had to keep up with you. I've had patients tell me, I couldn't keep up with my family before, and now they can't keep up with me.
Wow.
That's very gratifying to hear on behalf of that patient.
Sure.
I've had people who are 60 who tell me, I feel better at 60 than I did at 50 because I've lost so much weight. I can do so many more things. So I definitely want to emphasize it's also, yes, it's about health and diseases, and yes, it's about losing actual, pounds, but it's not necessarily about a specific number to get to. It is losing enough weight to do all the things that you want to be able to do and to increase your capacity and to try and get rid of some of your medical problems and avoid some other ones. So if you have high blood pressure and diabetes, even if you can't get them, even if they don't go away, you might be better controlled on lower medications, and it would avoid the downstream complications of like developing earlier heart disease. So now that your diabetes and high blood pressure are better controlled, you're less likely to progress your heart disease because of that. So a lot of preventative aspects to this as well. But the lifestyle and the things that people can do with their families and with their friends is really powerful.
Wow.
Also.
I'm sold. Like, that sounds amazing.
Well, not everybody needs it, clearly, right?
So that's actually another one of my questions that I wanted to ask you. When should someone start considering bariatric surgery as an option?
Sure. So, unfortunately, a lot of these surgeries are driven largely by insurance. So while our national society and the international society advocate for weight loss surgery at a body mass index of 35, so body mass index is your weight in kilograms over your height in meters squared. So that calculation, which there are BMI calculators on the internet, but basically for a body mass index over 35 or between 30 and 35 with an obesity-related complication, so high blood pressure, diabetes, sleep apnea, heart disease. So that would be considered by our national societies to be indications for weight loss surgery. Actually, in some Asian populations, they feel that that should be allowed even lower because Asians are more likely to develop medical-related complications to obesity at lower body mass indices.
Really?
So that was put out in 2022. Unfortunately, the insurance companies are still following guidelines from 1991, which state that you can only have surgery if you have a body mass index over 40 or over, or between 35 and 39.9 with a medical-related condition, or obesity-related condition.
Okay. And do you think the insurance companies are going to stick with that 1991?
I think that is antiquated, and I fully support the new guidelines.
Yeah.
Not to mention that our population is literally getting bigger and bigger.
Right.
We spend $173 billion on obesity-related healthcare.
Wow.
Per year in the U.S. That's B with a billion.
Yeah, that can't even imagine that.
So if we could help people and treat obesity at a lower level and begin to treat that, then maybe we could cut into that.
Right, before it starts developing.
Before people develop the associated comorbidities, yeah.
Right. Why do you think Americans are suddenly, I guess, like becoming more heavier?
Well, the pandemic did a lot, I think. But also we have very sedentary lifestyles. I tell people, hey, as a species, we used to run after our food. We used to run away from becoming food, right? Yeah. So right now we drive to the grocery store, and then we drive home, and then we drive to work, and we work, and most of us work at a desk and don't really get up, or if you do a little bit of activity during the day, but not nearly what is required for all of the calories and the easy calories, I might add, that we get. We eat a lot more processed foods. Right. We have a lot more preserved foods. We have a lot more fast foods. In 1980, the prevalence of obesity was only 13%, and now it's 40%.
Wow. That's scary.
That is scary. And it's a bad trajectory that I think we, as a generation, have to, or I guess as multi-generations, have to address and help our children not to go down that path. It's each of our responsibility to try and help the next generation. One of the gratifying things that I find about my practice is that with weight loss surgery and the instruction that we put into it for patients, that if we can teach them correctly how to eat, the lifestyle changes required, like exercise, and the amount of time that you need to commit to those things, if we can teach them appropriately, they can adopt that lifestyle, they will pass that on to their family and to their children. And wouldn't it be great if I have a patient who is overweight and learns these things, who's obese and learns these things, and then they teach it to their family, and their family member does not become one of those statistics, does not have to sit in my chair to ask for weight loss surgery.
Yeah, no, that sounds amazing. I guess your job is not necessarily just doing the surgeries, but also educating patients.
100%.
Avoid.
100%. So, a lot of people don't even know what the difference between a carbohydrate is and a protein. That seems crazy to people who are educated, but some people have a very low level of understanding this. It wasn't a priority in their family. Just food in general might be a priority in their family. Right. Just finding any kind of food because they're in a food desert, or their family just doesn't have the finances for that. So it's important really for people to understand the basics of protein, carbohydrate, fat, and then what are some examples of those things, as well as how to read a nutrition label. How do I use that to help me maybe meal plan? And what am I supposed to get in every day? And because I've had surgery, what vitamins do I have to take? So it's important that we make sure our patients have an understanding to be successful in the end.
Okay. Let's say somebody has decided that they do want bariatric surgery. What are some things that you think they should be aware of before coming and meeting a bariatric surgeon?
So I think people, if they're thinking about it, they should meet with a bariatric surgeon because, this is not an overnight process. This can definitely take a while for patients to decide. I've had patients who come to me and then it's 2 or 3 years before they come back and they say, oh no, they really want this. So it's okay to get a consultation and no one signs in blood that they're, if they come and see me as a consultation, that they have to have surgery, okay? No. So it's just for more information and for education. Our National Society of the American Society of Metabolic and Bariatric Surgery, so ASMBS.org, has a great section for patients, and that's a very reliable source rather than Dr. Google, for example.
Or ChatGPT.
Yeah, or ChatGPT. So that would be helpful. Just learning, trying to do some investigational research, but also, seeing a surgeon is fine. If you're actually, once you decide that, okay, no, I definitely want it, I really tell people you really want to be behind the surgery that you pick. Like, you want to be all in. Like, that's the surgery that you feel most comfortable. I mean, the surgeon will say whether one is better than the other for that specific patient, or maybe neither is better. And then the choice is, how do I choose? But if I'm a candidate for all the surgeries, then the one I can get behind the most.
Okay.
Not necessarily the one that loses the most weight or the one that the surgeon says. It's the one that I feel the most comfortable, because that way your participation and involvement will be the highest.
Okay.
And I think it's important for people to realize also that they need to have the time to do some of these things, such as lifestyle changes, as well involving exercise. So we talk about 150 minutes of cardiovascular exercise per week as a minimum, as well as the meal planning, that gets faster as people understand and how to shop. But one of the issues sometimes these days is people say, well, I don't have time. And in some ways, I tell people, you deserve this. You need to make the time. And if you really are going to say that you don't have time, and because you're working 2 jobs and trying to go to school, for example, it might not be the best time for weight loss surgery because you're not going to get everything out of it that you would like. And that goes for weight loss surgery or weight loss medications. You're going to get the most out of it if you can put a lot into it as well.
Okay. So you're essentially saying that once you have the surgery, you don't just go home and, everything's cured. You actually have to
work at it.
And
yes.
work and...
Yes. And we start that before surgery because usually with the insurance, there's a lead up time of things that you need to do beforehand. So during that time, we start educating patients, and we don't say, oh no, wait until surgery and then we want you to start exercising. No, after you come and see us, like, I want you to exercise now. Like, what are you going to do today to increase your activity level? And, the dietitian meets with people to talk about, how are you eating now? What are some easy changes that we can do to help you to start losing weight right away? So, for example, if people drink a lot of juice, okay, I tell people juice is just sugar. So if you instead of juice, eat the fruit. Okay, so when you picture a bottle of juice, I want you to picture just a bottle of sugar, because that's, if you look at the nutrition label, that's what it is. Similarly, sodas. Stop drinking sugared sodas. Stop drinking caffeinated sodas, because this country runs on too much caffeine. And then what happens is people realize, because caffeine will dehydrate you, people drink coffee and caffeinated soda, and they don't drink enough water. And so they start to cross their signals of, oh, I'm hungry, but maybe they're just actually thirsty because they're dehydrating themselves consistently.
Okay.
And so if you drink enough water, then maybe what you thought was hunger, which is actually thirst, it gets sated. Like, you feel better, and then you're like, oh, I don't need anything. I mean, because most people eat, but sometimes people forget to drink the correct things. Yeah. So just that kind of basic education, and, if a lot of people think about how much, even diet caffeinated soda, so Diet Coke or Pepsi, or, and then coffee, and how much water do you drink with that? And then you throw a juice in there, and then maybe they drink 1 cup of water a day, or I don't really drink water. I mean, you need to drink water.
Yeah, water should be the priority.
Yeah,
for sure.
Absolutely. 48 to 64 ounces a day is 6 to 8 glasses of water a day. I mean, it's been out there for a long time.
And you mentioned Diet Coke. What's your opinion on that? Do you like
diet sodas?
Diet sodas, yeah.
So I think if people drink caffeine-free, low calorie, like 0 calorie drinks, that's better.
Okay.
In patients we try to avoid that in patients who are, going to get weight loss surgery, because the carbonation, once you have the surgery, your stomach effectively is so small that the carbonation can make you feel uncomfortable. So we try and basically wean people off of these things ahead of time.
And before we get into the different types of bariatric surgeries, I'd like to touch up on what are some things, or what is the process like before getting the bariatric surgery? Do patients have to go see other types of specialties, other doctors? You mentioned nutritionalists earlier.
Sure.
Yeah.
So in our program, everyone has to see a dietitian, and that's nationally. You have to see a dietitian and work with them. Like I said, there's an important part of education. as well as patients will need to take vitamins lifelong. So which vitamins might depend on what surgery you've had and how much. So that would all be discussed with the dietitian. There's so many different vitamins out there that it's best to speak with the dietitian. One rule of thumb for multivitamins is we don't recommend gummies at all because usually they don't have enough thiamine. So no gummies, no multivitamin gummies, just the tablets. But for example, there are insurance requirements. So depending on what your insurance is, they could require you to do 3 months of attempted weight loss documentation before surgery, and that would be with the dietitian. So 3 consecutive months of weight loss documentation. Wow. It could be 6 consecutive months. Some insurances, unfortunately, are a year.
That's a long time.
It is a long time, and it's a deterrent that the insurance companies use to try and weed out people who are not committed. So in some ways, I understand that it's not just a one-off. Hey, come into the office, go get weight loss surgery, and good luck when you're done. Yeah. No, it's not at all like that. So the insurance companies on their part are trying to look for the commitment. It also gives patients at least a period of time where they can try out they can start changing their lifestyle. I mean, usually it takes more than 2 weeks. It takes at least 6 to 8 weeks sometimes to start changing your lifestyle. There can be so many things, and to put into place good habits that you want to build on. So there's the insurance requirements, that's one. There might be weight loss requirements from the surgeon, so to demonstrate that people are exercising, trying to exercise and eating right. And when I say exercise, it doesn't mean that you have to walk or jog, down the street. It might mean that, hey, before I couldn't really walk 2 lengths of my house, and okay, now I'm working on walking 3 lengths of my house all at once. So for different patients who have different exercise capacities, we might encourage different things. Some people tell me they can't, and we find ways for them to exercise. So that's a big thing. So insurance requirements, lifestyle changes, and then and weight loss requirements. And then patients have to have certain things for the insurance companies to pay for their surgery. So a letter of support from their primary care provider stating that, yes, I support this decision. This patient is a good patient in their opinion for this surgery. That they may have capacity to follow through and understand everything about the surgery. There's a mental health evaluation.
Really?
Do they have, that's required by our insurance. Do they have enough support from their family members? We don't want patients to feel like they're an island after surgery. So do they have a mental health illness that's going to prevent them from being successful or get in the way of them being successful? So it has to be okay up here before you can be okay everywhere else. Do they have a false sense of what this can do for them? So people have to have realistic expectations, and the surgeon and the dietitian need to help set those, but at the same time, people have to hear it and understand it, not just, I'm going to lose a bunch of weight and I'm going to be skinny and my life's going to be great and I won't be depressed anymore. No. It doesn't always follow like that, and that would be a misconception. So do people are people capable of understanding and carrying out with the surgery? So that's what the mental health evaluation is. Do they have support from family members? Some people rely on food as a support system, but after weight loss surgery, that's one of their best friends won't be there. Right. Okay, so remember, food can be accessible, it's comforting, it never talks back, doesn't disagree with you. Those are qualities of a good friend, right? That friend won't be there. So do you have something else? And for example, is your family supportive? Is it that they're truly supportive and those are the words coming out of their mouth? Or if you guys go to a restaurant after bariatric surgery, will they be the ones who say, oh, no, we're okay with not having the bread basket? Because that's going to be hard, if it's going to be hard for that patient. So that's supportive, that they're not going to buy sweets and snacks that might tempt the person having surgery, because that's kind of sabotage. So that's not, you can say the words, but people really want to see that your family members are supportive. And does the patient feel comfortable asking for that kind of help from their families? So mental health plays a large portion of our it's very important to our practice. Maybe you'll be okay if everything goes well with these surgeries, but it is surgery. There are very small risks of complications, but if that happens, are you going to have the mental capacity to handle that, and the emotional capacity and the support system to be able to handle that? So all of those things are really important. Again, as far as preoperative testing, that's primary care doctor support, mental health. We also have some radiology potential requirements. If you used to be a smoker, maybe you need a chest x-ray to see if there's any lung nodules that we need to look into, or if you we might get an abdominal ultrasound to see how big your liver is, because we have to lift up the liver in order to get to the stomach. So anatomically, is this reasonable? If you have heartburn, we may need a swallowing study. We may need a scope to look down into your stomach and the first part of your intestines. And then if you're of a certain age or have a significant number of medical problems, you might need to see the heart doctor. So a lot of these tests are patient specific. So the mental health evaluation and the primary care letter are required, but a lot of these are at the discretion of the surgeon. Okay. One of the things that I like to emphasize also is preventative care. So if people are not up to date on their colonoscopy or their mammogram, or their GYN exam, or they haven't had their PSA checked, I try to have all of those things checked and up to date, and encourage the patients to do so, because you really don't want to find out you have cancer right after you have weight loss surgery, because sometimes chemotherapy regimens or certain cancer treatments can really make patients malnourished and unhealthy, and you don't want to be in a state of losing weight from weight loss surgery when you have to have those treatments.
That makes total sense.
Yeah, and then I forgot to mention earlier, a sleep study might be necessary for some patients to find out if they have sleep apnea, which everyone thinks is a sleep thing, which is actually a lack of oxygen getting to some of your vital organs while you're sleeping. It occurs during sleep. But sleep apnea, if left untreated, can lead to heart and lung disease. So it's not just help me sleep better. It's really preventative as well. So multiple tests to really help benefit the patient, and know that if they're going to undergo this, they're not going to have some, potentially, devastating cancer diagnosed right after.
Wow, so it's like a big, lengthy process.
It can be. I mean, it can be short too. For some patients who don't need all of those things, you might need just the primary care doctor, the mental health, an EKG, and either a swallowing study or a scope, and that's it. Okay.
So it just depends on the patient.
Yeah, and then also we do get a whole bunch of preoperative labs, and most programs in the country will as well, because all these surgeries can affect people's vitamin levels. And it's easy to say, vitamins, they're just vitamins. Yeah. but vitamins help us to see. They help us to think clearly so that we can hold down a job. It helps people to walk straight. It helps people to have good balance. They do some vital things. It helps us to have energy because we have enough iron in our system and we can create blood. So they are actually very important. So we check people's vitamin levels beforehand. So if they're low in certain things, we can supplement them beforehand. And then afterwards, we track those vitamins carefully to make sure they're not going too low or too high, because people can have issues either way as well. So it's very important to follow.
Okay, now that we mentioned what patients have to do pre-operatively, I think it would be nice if we can actually talk about the specific types of bariatric surgeries. Let me just check real quick if we're still recording. Everything's good. So, Dr. Lee, can we go over the types of options that patients do have for bariatric surgeries?
Sure. So, probably the most popular worldwide right now is the sleeve gastrectomy. So that's where we take out about 80% of a person's stomach, and we literally make it into a long, narrow tube. Some people talk about it as a banana, but it's kind of the shape of a sleeve. And so it's called the sleeve gastrectomy. Gastrectomy meaning taking out the stomach. And that allows people to lose weight because they have less space in their stomach, so they feel fuller faster, and they are less hungry because we take out a portion of the stomach that is responsible for a hormone that stimulates hunger. So it works on two different levels. There's the gastric bypass, which is where we cut your stomach and rearrange your intestines to help limit the amount you can eat and feel fuller faster. Also to not absorb all the nutrients that you would normally with regular digestion. And then there's also a hormonal component which involves multiple hormones because of the intestinal rearrangement to help people lose weight. So that actually has it's bigger surgery, but there's more mechanisms for weight loss. And then there's the duodenal switch, which most people are doing what's called a SADI, or a single anastomosis duodenal ileostomy, which is you get a sleeve and an intestinal rearrangement. So the intestinal rearrangement is more significant. That one's only about 2% of bariatric surgeries right now. It's a very small percentage, but it is gaining in popularity, for example, as a revisional surgery from patients who might have already had the sleeve, for example. But that one also works with limits the amount people can eat because of the sleeve already. It has a very strong hormonal component and a very big malabsorptive component. And the more malabsorptive a procedure is, so the SADI potentially is, and the duodenal switch is potentially much more, or it can be more malabsorptive than the gastric bypass. So people might have to take more vitamins. And the way I often explain malabsorption, I think I explained it to you before, is if you think about corn, you eat corn, and then a couple days later you look in the toilet and you're like, oh, I had corn. And when you have either a gastric bypass or a SADI, and you have more malabsorption, then all of your food becomes more like corn. So a lot of those nutrients and the nutritional value of that food may be in the toilet. Now, it's not as graphic, so you don't say, oh, I had turkey and green beans, and corn. It's still just the corn, but I mean, that's how an easier way I find for people to think about it. And that's why with malabsorptive procedures, people need the vitamins because some of them are being wasted. And you can't take a handful of vitamins once a day. You might have to space them out throughout the day because your body just can't absorb that much at one time. So for example, we might say, hey, you have to take a multivitamin twice a day. Well, if you take 2 of those at one time, well, one of them might get absorbed and one of them, your body just can't take that much at that time, so it gets swept away. So, if your doctor says, take this twice a day, try not to take it 2 once a day. It doesn't make it more efficient.
Okay.
And it just wastes that money, so.
Right, okay. So I noticed that you mentioned there's a malabsorptive benefit, restrictive, hormonal. Those are the main 3, right?
Mm-hmm.
Okay, and then, so for example, the gastric bypass, is it all 3?
Okay. So the sleeve is restrictive and hormonal.
Okay.
The gastric bypass is all 3, and so is the single anastomosis duodenal ileostomy, or the kind of the latest version of the duodenal switch. But with these surgeries, you really want to follow up long term because of those potentials for vitamin deficiency. So we recommend, and in our program, we follow all of our patients lifelong. Now, do they all come back lifelong? No, but would I like them to? Yes. And a good patient, for example, I would say, most of our patients are women, and we do have, probably 30% are men. 35%, but 60 to 70% of them are going to be women. And we say, okay, PCP, GYN, us, every year for the rest of your life, potentially. Or whatever scheduling that provider asks for.
I remember there was a patient that I saw with you. She came back after 12 years. That's incredible.
Yeah, no, that's great. And, that only enhances people's care. One of the things about follow-up is not only are we checking people's vitamin levels because people's diet, they change over the course of a year potentially, but also we're making sure, how's your exercise going? Do you have some limitations now that you didn't before? Hey, maybe we can help you with new ideas to exercise. I sprained my ankle so I can't exercise. No, that's not actually true. You can exercise with a sprained ankle, but obviously you don't use your legs to exercise. You don't use your legs to exercise. Yeah. So we help patients with those ideas and help them to empower them, as well as check on things, check on their vitamin levels, check their weight. Hey, are you maintaining your weight loss? Have you changed your diet? Are you still getting enough water every day? Are you sticking kind of to the how much protein we talk about that people should eat? So we try to follow up with patients and make sure kind of that they're staying on the right track. Usually patients forget something between 1 year and the next. And I had one patient tell me, she's like, oh, that's why I come to these follow-ups, because, between 1 year and the next, I might forget something, and next year I might forget something different. But by coming, you remind me of these things, and it helps me to stay focused in with the program. And I think the patients, some of our most successful patients are the ones that follow up every year just to make sure they're doing things correctly, and that's great.
Yeah. Okay. How do you choose what specific surgery should patients get? Sure.
I mean, that is a more complicated question, and I would encourage everybody to think about what they might like when they're researching, but then also listen to what their surgeon would tell them. It can depend on your surgical history. It can depend on some of the medical problems you currently have. So if someone has really bad heartburn that's not potentially a small anatomic problem, then we might encourage them to have a gastric bypass. But if you have a little bit of heartburn, you might still be able to get a sleeve.
And why is that?
Well, because one of the possible complications of a sleeve is heartburn. And so about 25 to 30% of patients develop heartburn after a sleeve. And normally that can be treated with medication, but it can get so bad and can potentially be resistant to medications. So patients with significant heartburn are often guided towards a gastric bypass, which is an anti-reflux procedure. If you take diabetes, all three procedures will help with diabetes, but in order of increasing malabsorption, it might be better at treating diabetes. Sleeve will help, but a gastric bypass, for example, will help more. And a single anastomosis duodenal ileostomy, or the SADI, may help even more than that, although that one's not being done very much. So I'm going to just mainly talk about the gastric bypass because it's more commonly done. Little less risk of severe vitamin deficiencies, although like I said, there were significant vitamin deficiencies with the duodenal switch, a little bit less, definitely less so with the SADI, but certainly with the gastric bypass and the SADI, you can get vitamin deficiencies that are even more significant than the sleeve because of that malabsorptive component. The patients, for example, who already have a malabsorptive component, like Crohn's or ulcerative colitis, we don't recommend that they have a malabsorptive procedure. In particular, Crohn's, for example, requires surgery on their small intestine. So you don't want to do surgery on their small intestine ahead of time. Just in case. So there are various considerations that the surgeon will also take into consideration. But the diabetic effects, I tell you, are significant. So if someone's had diabetes only for a little while, or they're being managed on oral medications, a sleeve might be good. But for someone who's on a significant or a moderate amount of diabetic medications and insulin, as well as oral medications, I've had those patients who are poorly controlled on their insulin and their oral medications. Sometimes I've had them go into remission.
Really?
Yeah, from their diabetes. So that means no insulin, no oral medications. I've had patients on an insulin pump get to oral medication alone, and that's a huge game changer for their lifestyle. Now, I use the term remission because if patients gain weight, these can come back, or there can be progression of disease, to be perfectly honest, as well, even in spite of trying to get them under better control. So, I mean, that can happen, but to be able to control their diabetes so much more easily and make the medications more effective, that's very powerful for patients. Yeah. I've had patients who come because they're bad diabetics, and they say, Dr. Lee, which surgery should I have? And, barring other things, I say, you need a gastric bypass. And they say, well, I do like the sleeve better. And I said, well, if you can't just bring yourself to mentally accept the gastric bypass, then the sleeve will still help. But if you are considering, if you really want the biggest effect on your diabetes, I would say, gastric bypass, or potentially, if you're going to be very good about that follow-up, then potentially a SADI or a duodenal switch. But really the gastric bypass and the sleeve are probably the most common surgeries worldwide.
So does the gastric bypass cure diabetes?
Doesn't, like I said, it's remission. Okay. It's, potentially. It doesn't cure it. If you get the gastric bypass and you don't follow the things. So I have, for example, I have a patient, of course I have a patient who's had this, right? So had a patient who was over 300 pounds, moderate to severe diabetes, was on some insulin, had surgery, didn't do really anything that we asked them to do, didn't exercise. I brought that patient in extra to explain how, yes, you really have to exercise with the surgery. You really have to participate from the lifestyle changes. And at the end of the year, the patient had lost 30 pounds. For 30 pounds, it's not worth getting the surgery because they didn't also participate. Their diabetes still was improved after a gastric bypass, but a lot of the other health, like their diabetes would have been even better had that patient participated.
Right.
So patient participation, it has to be there.
Very
That's
important.
why I say, people have to have the time. And it doesn't need to be a lot of time, right? Does it need to be, hours every day that I have to devote to my weight loss journey? No, but 40 minutes, 30 minutes, multiple times a week. Yeah. Do you have to be responsible and weigh yourself regularly so that you're aware, right? Because people need to take, hey, what that number says on the scale, I participate in that. You have to accept that responsibility.
And I remember when I was working with you, you said something very nice. You said usually doctors give medications to patients, but as a bariatric surgeon, you try to take them away.
Yes, right. So, for example, a lot of times with insulin requirements, patients can come in on a certain amount of insulin. They might get surgery one day, and we can see their sugars going down overnight. I mean,
Wow.
It's amazing. And a lot of times to start with, I'll send those patients home on half of the insulin that they were taking the day before. That's great. I might be able to take off one of their blood pressure medications soon after.
And it's that quick, like the day after the surgery?
It can be, yeah,
Wow.
absolutely. Now, less so with the sleeve, but certainly with the gastric bypass, I've done that for patients sometimes. Or if they're on an oral medication, I say don't take that when you go home, and we'll follow up on your sugars just to make sure you don't need it again. But yeah, it works that fast.
Amazing.
Yeah, I mean, it's not magic, but there are times in my profession when it sometimes still feels a little bit like magic. And, one of the other things, the experiences that I have with my surgery, the surgeries I do, is that people say, "Oh, Dr. Lee, thank you so much. You've changed my life, by doing this surgery." And I really, early in my career, I was like, "Oh yeah, no problem. That's great. I'm happy to help." And then I realized, wait a minute, it's not me. It's really the patient. It's the patient who every day commits to, yeah, I'm going to make some time to exercise. I'm going to eat right. It matters what happens. I'm going to weigh myself. So it's those patients, those patients are successful because they put in the work. I give people a tool, a kick in the pants, I'm a really good cheerleader, but it's ultimately the patient. You're the person who walks through my office. You're the person who commits. And when I get to take those medications away, it's a win for both of us. So, and again, the thing with the kids, like your kids won't have to sit in my chair. Right. Hopefully, all that stuff is really gratifying.
Yeah, I'm sure it is, yeah.
I mean, those are the priceless moments. Like, you've lost this much weight, but you're off your diabetes medications and you can run after your children, or they have to run after you now. Hurrah.
Yeah.
That's a win.
And I wanted to ask you, is there an age for bariatric surgery? Can you be too young to have bariatric surgery?
Yeah, most programs in the U.S. will not consider bariatric surgery unless you're 18 or over. Certainly, it is available for older adolescents, but in a highly regulated program, such as children's hospitals. And I won't get into those reasons, but there's actually not necessarily an upper age limit. At least not yet from the insurance companies. So some people say, well, am I too old for bariatric surgery? And I want to say my oldest bariatric patient is 84.
Wow.
However, I will say that if you can reach 84 with multiple comorbidities, the likelihood is that you probably won't die from your obesity-related comorbidities. But I have had patients who have benefited from it, even when they're older.
Okay, that's nice. And let's say you operate on somebody, how soon can they return back to their normal activities?
Sure. So I expect people to get up and walk around the night of surgery, for example. So you're walking right away. I didn't cut your legs off. There is some pain. It is surgery. But most people, for example, driving, have to be off the narcotics. But also, a lot of people do drive to my, 1 week, which is around 7 to 9 days. They come to their post-op visit. Maybe they drove. If they're in too much pain, then, someone else drove. But usually we say no lifting over 10 pounds for 4 weeks.
Okay.
But stairs are all okay at the beginning. That's really the only physical limitation. We usually will sign people's FMLA for work. And we usually give people 3 weeks off from the surgery, not so much for the physical recovery, but for wrapping your head around how much do I have to drink the protein, I have to get in protein shakes in the beginning because there is a special diet. I have to get in protein shakes in the beginning. And then I have to take my vitamins and which vitamins do I have to take when and how much protein, and I'm so full, so how do I get it all in when I need to? So that can be challenging. That the management part can be difficult, not just the physical component to it.
Okay, and you mentioned diet. What kind of changes does a patient have to make either to the vitamins they take or the diet post-surgery?
Yeah, so in the beginning, before surgery, we usually start people on a multivitamin if they're not taking one, but only one a day. After surgery, we actually, for the first 3 months with a sleeve and for the first 6 months with a gastric bypass or SADI, you might be on chewable bariatric vitamins. And then you can return to the regular over-the-counter ones. But because those are the highest periods of risk of getting vitamin deficiencies, we really want them to be chewable. They can be liquid. And as long as actually people can find things over the counter, and we have it checked with our dietitian. But generally, kind of special vitamins for 3 and 6 months. But people will generally need to take a multivitamin, calcium citrate, and then some people need to take iron, some people might need to take B12. And again, we will be checking people's vitamins as part of a post-op regimen. But as for the diet, usually we do 2 weeks of liquids, then 2 weeks of soft foods, and then a regular diet. Remember, with most of these surgeries, your stomach has changed in size. So there's a period where, you're trying to get used to how small that actually is. And people eat a shockingly small amount after surgery. So a lot of times they need to be supplemented by liquid supplements like protein shakes or protein shots, so to speak. And there are not, or protein drinks. And all protein drinks are definitely not created equally, which is why we have recommendations from the dietitian and things like that.
So you actually work with dietitians and try to
Absolutely.
A plan
Having a good dietitian as part of the program is really important. And they don't have to be like working, next door, but they, any good bariatric program will have an associated dietitian with it.
Okay. And you mentioned that, you make the stomach significantly smaller.
Mm-hmm.
Is there possible that it can stretch out again and become bigger?
100%. Okay, because the stomach is a muscle, so it's stretchy. Okay, I had a patient who actually, when I was in training, this is a long time ago, when I was in training and he was seeing the surgeon that I was working with, and he said, well, when I had surgery 5 years ago, no one told me that I had to eat a certain way. No one told me I had to exercise. And now I can eat a whole pizza again. A whole pizza? No. I did have a patient who had a sleeve who she came back. She's like, you made my stomach too big because I've had a study that shows that my stomach is a lot larger. And I said, well, this is what your stomach looked like right after surgery. And I showed her the study. And she's like, oh, wow. Okay. She said, because now I can eat a whole Whopper. And I was like, okay, you're not supposed to be eating a Whopper after these surgeries. So that statement's wrong on a whole bunch of levels. But suffice it to say that yes.
So what can they do to avoid
stomach is stretch? Well, is again to follow the recommendations of the surgeon and the dietitian. Okay, so eating multiple small meals throughout the day. So we say 3 small meals and maybe 1 to 2 snacks, or 4 small meals and no snacks. When I say snack, I don't mean, I'll have a handful of cookies or even a little bag of nuts. No, I will have a serving of a high protein snack. And we ask people not to skip meals, because usually what happens when people skip meals is they get, they're fine because they skip that meal, but then when they get hungry, they get really hungry, and often people will eat too much. They'll eat whatever they have at hand. They'll eat the wrong thing. They'll eat it too fast. I mean, how many of us have done that, right? Every one of us have done that, right? Or it's like going to the grocery store when you're hungry. I'll take this and I'll take that and that, but that's not good for me. But I'm so hungry. That sounds really good. So, just like going to the grocery store when you're not hungry, we tell people you eat because it's time, not necessarily because you're hungry, because that way you go through your day, and if you're not hungry, you make better choices when it's time to eat. You can eat it more slowly, and you can chew your food. You can enjoy it rather than, trying to get it down.
We all struggle with that.
Yes, we definitely do.
I wanted to ask you about Ozempic.
Sure.
The big...
So, anti-obesity medications, yes, right? Or weight loss medications. So, absolutely.
What's your opinion on that? Has it affected your practice in any way?
Absolutely. It's definitely affected our practice. Because people think, I can have weight loss medications because people don't want surgery. I get that, okay? And are they effective? 100%. They are very effective these days, but they have limitations. I mean, for a patient who has a body mass index where you're 150 pounds overweight, will it help you to get to more normal weight? No. Okay. So usually, and it's very much, how well you do with weight loss medications can depend on whether you have diabetes or not. So diabetics tend to have a lower response rate by about 5%. So most weight loss, so let's take the ones that are currently available on the market. So semaglutide and tirzepatide. Those are the generic names. It would be Wegovy and Zepbound. Those would be the brand names, exactly. But semaglutide, so I don't want to show affiliation, so I'm going to use their generic name. So semaglutide, that one, if you're not diabetic, you can lose up to about 15% of your total body weight over the course of a year or a little bit longer. This is not immediate, okay? And if you're diabetic, though, that might be down to 10%. Same thing with tirzepatide. It can be up to 20% weight loss, but If you're diabetic, it might only be 15% of your total body weight. And so when I say your total body weight, if you're 300 pounds, you might be able to lose 60 pounds. But you say, well, then you're still you're still 240 pounds, and if you're 5'3", that's still a lot of, you're still, depending on how tall you are, maybe 100 pounds or 80 pounds overweight. So maybe you're a better candidate for surgery, because you'll lose more weight and then not have to stay on another medication. Yes, you might have to stay on vitamins, but somehow that feels like less than medication. These medications have been around for diabetes, but have people been taking them, for a long time? No, because really the first GLP-1, which is one of the ways these surgeries work, these medicines work is it's a hormonal mechanisms. These didn't come out until the early 2000s. So people have been on some type for 20 years, but is that 50 years? That isn't. We've been doing the gastric bypass for over 50 years. So we know that works. We know it's safe. When you start on these medications, sometimes it's a lifelong thing. Can you potentially be weaned from some of these medications? Yes, but it doesn't happen in very many patients. So what we're doing in the bariatric surgery world is we're actually using medications in conjunction with surgery. So we might have patients who have had surgery and they've regained some weight. We might put them on a course of anti-obesity medications. And there's more than just semaglutide and tirzepatide. There are some that might be better, like if you develop night cravings, maybe that medication will help you to control those a little bit. So really matching the right medication to the right patient is also important, but we might be able to help that patient be on medication for a while, and then could we wean it off? Yes. And we might have patients who are, I said, we're talking about body mass index. I have patients who have body mass index in the 70s or higher. So helping them to lose weight before surgery can be very important. And then maybe we can get them off after we do the surgery and see how well they respond to surgery. And if they need more medication after surgery, we will incorporate that then. So it's actually another tool in our wheelhouse as a bariatric surgeon. But a lot of times patients don't understand that there is a limitation to these medications. So that's very important, how these surgeries can work together and to use them in consultation with a physician.
Right. And how do you help patients decide between a weight loss medication or surgery?
Well, we talk about their goals and their fears and, what the purpose of losing the weight is. Losing weight definitely will help people with medical problems. Just weight loss in general, whether you do it by your own lifestyle changes and exercise, whether you do it with that and medication, or lifestyle changes and exercise and surgery. So you need to just form a plan on what's best for the patient, and being realistic. What are the goals, and what do you think you can do? A gastric bypass is likely to impact somebody's diabetes a lot more, potentially. It can be a diabetic medication as well, so it will help with the diabetes, but it's right. Treating it, it's not, and it is helping to improve it by losing weight, but because of the intestinal rearrangement, the gastric bypass can potentially make a more significant effect. Also, it matters a lot based on these days with people's insurance. So, for example, Medicare and Medicaid do not cover weight loss medications, except Medicare will cover semaglutide if a patient has pre-existing heart disease. and meets the criteria for obesity. So the criteria for weight loss medication is different. So if a patient has a body mass index of 30 or above, or a body mass index of 27 with comorbid diseases, then they are eligible potentially for weight loss medications. But patients' insurance companies, their employer can carve out and say, we don't want to cover that. So, for example, at this very moment, I can't speak towards the year coming. For example, the state of Maryland, anyone who's under state of Maryland Blue Cross Blue Shield, it's just not covered. Okay,
So what would they have to do?
the medication is just not covered. The surgery is covered. Almost all insurance companies do cover the surgery, okay, because it is a proven method of weight loss. But not necessarily the medication. And I will say, for example, with women of childbearing age, okay? So if you say, when you're in your 20s or early 30s and say, I want to lose weight, I just want a weight loss medication, okay? If you lose weight with a weight loss medication, well, if you become pregnant, you have to come off the medication because it's not a medication that's been tested or safe with pregnancy. So not only do you have to come off your weight loss medication, but you also are more likely to gain, most women, not men, most women are more likely to gain weight during pregnancy. So first of all, if you stop these medications, the natural history is for patients' weight to go back up. So people think, I can lose a bunch of weight and then stop these medications. Not actually. It's like a blood pressure medication. So right. I have high blood pressure. I take my blood pressure medication. It controls my blood pressure. But if I stop my blood pressure medication, what happens? Your blood pressure goes back up. Okay? But if, same thing with the weight loss medications. If I stop my medication, my weight's going to go back up. Okay. The one thing with surgery is afterwards, it's not necessarily, you're not on a medication because it's surgery. Right. Actually for women of childbearing age, unless it's going to be one of those things where I'm pretty sure I can wean that patient off the medication, I might talk to the patient about, hey, you might want to consider surgery. And weight loss surgery, even though it puts patient in the high risk pregnancy category, actually, if they lose weight with weight loss surgery, they have less potential for pregnancy and time of delivery complications. So bariatric surgery for an obese woman of childbearing age can be very beneficial and actually can increase patients' fertility. It can, decrease your risk during pregnancy and at the time of delivery. Great. Yeah,
sounds amazing.
Whereas my weight loss medication, I have to stop that during my pregnancy. Right. And certainly there are some patients who should not at all be taking those kinds of injectable weight loss medications. So patients who have had a history of medullary thyroid cancer or in their family, because it can increase that. Patients with a history of significant pancreatitis, or patients with a family history of something called multiple endocrine neoplasia 2. So, and that would include medullary thyroid cancer as well as a couple of different other cancers. I mean, that's much more rare. But certainly people should not be trying to be their own doctor and dosing themselves. People get very sick potentially from these medications, even when they're under medical care. So this is definitely not the kind of thing that you should be making independent decisions about, or writing away, or mail ordering these medications just because. I mean, this really should be under medications. We still use our dietitian. I still ask patients to take vitamins. We check their labs before we put them on the medication. So it shouldn't be taken lightly. And providers who are not checking these things, not counseling patients on diet and exercise, I don't feel like any provider should be just writing them. I think you should have some familiarity with the field of obesity and what's required to get the best out of these medications.
Right, and like you mentioned earlier, we don't really have enough research on the long-term effects of these medications. Is that correct?
Yeah.
So you want to have these checkups yearly.
Absolutely.
Okay.
Absolutely.
And a lot of people that I know personally, what they do is they go to foreign countries like Turkey or even in South America to have bariatric surgeries and then come back to the States or Canada. What's your opinion on that?
Well, you really want to ensure that you're going to have good aftercare. Okay, so first of all, I would say, for example, in the U.S., why are you not doing it here? Are you impatient? I would say some of the time before surgery is necessary. Maybe not a year, but 3 months to 6 months, that's a reasonable amount of time to generate good habits and work on developing an exercise regimen that you can maintain lifelong. So if you have to exercise 2 hours a day, that's not sustainable. Okay, that's not what I mean. But develop an exercise regimen that you can fit into your lifestyle. But insurance covers it generally. I mean, you might have certain places that don't. But for example, for Canadians who it might be more difficult to access, having in place aftercare ahead of time is important because many providers will not take care of you if you've had essentially tourism surgery. Why? Because it's hard to get an operative report, or there have been cases where they say they've done surgery and maybe they didn't. And you have the scars, but you didn't actually have anything happen on the inside. I mean, there are scary stories like that. Now, I'm not saying that all of the places are like that, 100%. There are plenty of well-reputed or, reasonable surgeons throughout the world who are doing these surgeries. But, I think the aftercare is as important, if not more important. The education component, making sure, I would certainly do your research as far as going to these programs. Hey, do they provide me with education about what I'm supposed to take afterwards and lifelong? Do they check my labs ahead of time? Do they check my labs afterwards? Do they ask me for any things about myself beforehand? I mean, honestly, a lot of these places who do it's like medical tourism, they're in it for the money. Okay? Do they care about you? Yeah, like around the time of surgery, but okay, goodbye. Good luck. Okay? I would encourage you to be, especially if you're considering that, to be an advocate for yourself. Okay, this is a responsibility, so how do I take care of myself afterwards if I have a problem? Is there a bariatric surgeon who's willing to take care of me if I've had surgery somewhere else? Many, many bariatric surgeons say, you have to go to the ER, or no, we won't take care of you unless you're having like a dire emergency.
And why did they say no?
Because why didn't you have care here? Why didn't you start with the care here? People will take care of you, but, are we not okay? Or is it, did you not want to go through the process? Maybe you weren't even a candidate for surgery. Okay, so maybe your BMI might be 29 and you had surgery, or even, if you have a BMI of 26 and you got weight loss medication somewhere else and now you're having problems and you want us to fix that, why isn't that surgeon fixing that? Okay, with my patients, if I take care of them, I'm going to take care of them. Like, whether you do well or if you have a complication, I'm here for you. Okay? Yeah. And that's how I feel a surgeon, not just me, but I think many surgeons feel like, we want to be helping our patients, to be getting patients from surgeons who might be halfway across the world who just do the surgery. And so if you don't have to take care of the patient afterwards, you may care less about what kind of problems they may have. Right. So they may say, well, I can definitely help you to lose weight. I'm going to make your sleeve really small. But then they come back to their home and now they can't swallow anything. Well, the surgeon over in another country might be like, oh, too bad, good luck, go see someone, maybe someone around you can help you.
Yeah.
And that's not really taking responsibility, I feel, as a surgeon.
Good point. Now, let's say somebody really wants to go do it abroad. What are some very important questions that they should have answers to before doing that?
Well, like I said, am I going to have aftercare? Okay, do I need, or what kind of education will I have from that program? What kind of support will that program give me, even if I am half a nation, or half a world away? Will I still be able to reach out to them for help? Do they have resources or connections maybe in my country? I don't know. But that's what I would encourage. Do your research. Are they affiliated with the International Federation, or if so, which is the International Obesity Society? Are they related to them? Are they a surgeon that follows those guidelines? So it has to do mainly with before and after care and education, because patients really need to know what they're getting into and how to take care of themselves afterwards. And if I have a problem, should I go back to that surgeon? Are there surgeons who are willing to take care of me? Do your homework beforehand. But in the States, because it is so widely available, I don't recommend it.
Just stay here.
Get it done here. And if you don't qualify, there's a reason you don't. Well, with our new guidelines, I'm definitely going to call that into question. But I think insurance companies, they very well should be under a lot of pressure from patients, from our societies to say, hey, we need to change these and make surgery more accessible to patients who really do qualify under our new guidelines. It's a disease, and we know best how to treat it. Let us get to treating these patients.
Okay. And if you don't mind, can you share some patient success stories with us?
Oh my gosh.
One of your favorite ones.
So this is an extreme. I'm going to admit that ahead of time. So I have a patient who was over a gentleman who was over 400 pounds, and he came in, and he was on the younger side. He had trouble even when I told him, hey, you need to start exercising. He took it to heart and he started walking. And he said, wow, it is so hard just to walk those 20 minutes that I'm starting with. But he kept at it, and he slowly was able to do more. He had his surgery, he was able, and then he really was able to lose even more weight. And he got going really well, and he got really into his exercise. And he was losing so much weight that at one point, because he was really tall, I was like, okay, dude, you're too skinny, okay? And that almost never happens. So I said, okay, I need you to work. I still want you to work out, but I want you to lift weights, okay, and build muscle. So we built some muscle, and then he started getting into triathlons, and not just any triathlon. Then he did Ironman triathlons, which, if you recall, is like a 2-mile swim, I think it's 150 miles of biking, and then a marathon. And then once he did 2 Ironman triathlons back to back from one weekend. Yeah. Hello. And then the triathlon people did a video special on him.
Wow.
Okay, so that's an extreme. Okay?
Were you in the video?
No. I don't think they even mentioned surgery, which I might add is a very personal thing. Do people need to say they've had surgery? No, but they need to tell their closest family and friends for that support aspect. But the general population doesn't need to know. and that definitely can get into various emotional things between family and friends. But suffice it to say, other stories. Let's see. So again, some of the people who tell me, like I said, I feel better at 60 than I did at 50. We do spotlight speakers who, say, hey, I was able to recover from my diet, I'm not diabetic anymore. And, they may still be 50, 40 pounds overweight, but they've lost 100, 120, 150 pounds, and they feel great. They don't have that huge person on their back. They traded them in for a small child, and they can get on the roller coaster. They don't have to have that walk of shame in front of their family. They can fit into a plane seat very easily without, hey, I need a seatbelt extension, or I even might need a second seat, or I'm really uncomfortable in my chair. Movie theater seats, even just regular chairs with arms. I can get into that. Yeah. I've had patients tell me, hey, and actually this was a police officer. They told me, hey, now I can, I can go to a diner or I can go to a restaurant and I can fit in the booth. I don't worry that I'm not going to fit in that booth between the chair and the table. Right. Or between the bench seat and the table. I had one patient, she told me that her seatbelt when she, before surgery, was really uncomfortable, so often she would drive without her seatbelt, and she knew it was illegal, and she got multiple tickets. She was stopped by the cops. She got multiple tickets, and she's like, now I don't get stopped because my seatbelt fits and I can wear it.
So it's a lot of things we don't even think about.
Absolutely. Patients who tell me, I don't need to use big and tall stores anymore. I can go into a regular store, try it on, and walk out. Okay? My shoe size has dropped. I can find shoes more easily. My neck size has changed. I can wear clothes that I had bought, years ago. I have this whole wardrobe that now, I wanted to wear these clothes, and now I can wear them. Now I can, I had one gentleman who said, who had twins, beautiful girls. He said, now I can put both of them on my lap. I don't have to put them on my belly. They can sit on my lap. Yeah. Patients who tell me, I can reach down and tie my own shoes. I don't have to get someone else to tie them for me. And we don't even think of these things. Those are the joys. That's not even part of the, yes, it's healthier to lose this amount of weight and you will be able to do stuff. Well, those are the kinds of things.
You get to live life again.
Yeah. I mean, not to say that they didn't, but it can be more rewarding, especially if you value those things.
Right. And just for the last 5 minutes, I have quick rapid fire questions, if that's okay with you. Let me just make sure one more time that we're good here. And
is that your?
That is my phone, yes. Okay. And what's one piece of advice you'd give somebody considering bariatric surgery?
There's so many. Do your research. Be all in. And be committed. Be ready to work.
What's a common mistake people make after bariatric surgery?
They think the surgery will do it for them. Hopefully we've educated them.
I hope so.
But that they feel the surgery will do it and I don't have to participate. Or their exercise falls off because of a trauma in their life or something. I tell people exercise is great for stress. So please exercise because it will help your stressful situation. Don't stop because you think you'll have more time. You don't really gain that much more time, but you take better care of yourself if you're sticking to your habits and exercising and eating right.
Okay. What is the biggest myth about bariatric surgery?
That it's easy. it's the easy way out. It is not the easy way out, okay? Obviously, we've been talking about it takes commitment, it takes work. It gets easier after you've had it, it gets easier. The beginning is hard, but it gets easier. But it is not easy. So even if you have a friend who's getting that, that's not the easy way out. But you really want that much help, and it can give it to you. But it's not easy.
Okay.
But we try and make it easier as, part of the education process.
Okay. And do you feel satisfied with your career?
Yes.
I can feel that
I
energy.
feel very satisfied.
I feel like you do.
I love being able to help take care of patients and, influencing them about their lifestyle and being part of that journey, because it's a journey that lasts people's lifetime. Because if you can lose weight and keep it off for a lifetime, that's impacted you, that small contribution I might have made, whether it be through my counseling, like I said, a tool and a kick in the pants, or just education. That's very gratifying for me as a person to help another person in that way. So absolutely.
Right. Do you have any advice for residents or medical students that do want to go into bariatric surgery?
Yeah, I would say learn, be open to weight loss medications and developing new technologies, developing new procedures. All surgery residents are learning about robotics, but don't forget about potential laparoscopy skills in case, your hospital may not offer robotics in the middle of the night. But it definitely, also I would say that in bariatrics, because medications are coming along, make sure you're doing other kinds of surgeries and that you don't pigeonhole yourself necessarily into one thing.
Okay. And can we end off with a story that you once told me about the lady that started to feel her ribs again?
Oh, yes. So that's a wonderful patient. And she said to me, she was feeling her body after maybe, a year of weight loss surgery, and suddenly she felt something hard. And she was like, oh my gosh, I feel something hard. And she called her sister, who's a nurse, and she's like, what is that? Dr. Lee must have left something in there. She's like, honey, those are your ribs. You've got some on the other side. She was like, oh my gosh. Wow, I can feel my ribs. That's really exciting. And she had also noticed that she had collarbones, a few months before that. She was like, wow, look at that. Like, who knew I had these things, right?
Yeah. That's an amazing story. I think I'll never forget that one. Like, it's just things that we don't even think about.
Well, a lot of people don't think about
being able to put on the seatbelt, feeling your ribs.
I've had patients who tell me, I got promoted after I lost a bunch of weight,
really?
Which is sad because obesity can be one of the last kind of socially acceptable forms of discrimination. No, okay? I try and assure patients that I know patients are beautiful already because of up here and what's in here.
Right.
Beauty doesn't only come from physical appearance.
Right.
Okay. And there are beautiful people, and sometimes we talk about it like as a journey, as an emergence, because you feel like, you're gaining that new sense of self and emerging, like the caterpillar to the butterfly. Like, right. I'm emerging.
Right. Well, I really appreciate your time.
Yeah.
Thank you very
This is great.
much.
This was fun.
Appreciate it. Thank you.
Absolutely.